Hey everyone, welcome back to the channel. Today we're diving deep into muscular dystrophy, a group of genetic disorders that progressively weaken the muscles over time. This is a complex topic, but I'm going to break it down in a way that makes sense, walking you through what's happening in the body, why it happens, what signs to look for, how doctors figure out what's going on, and what can be done about it. So let's jump right in. Muscular dystrophy isn't just one disease, it's actually a whole family of genetic disorders, and what they all have in common is that they cause progressive muscle weakness and degeneration. The word dystrophy literally means abnormal growth or development, and in this case, we're talking about muscle tissue that doesn't develop properly or breaks down over time. Now, there are over 30 different types of muscular dystrophy, and they vary quite a bit in terms of which muscles are affected, when symptoms start appearing, how fast the disease progresses, and how severe it becomes. But the underlying problem is always related to defects in the genes responsible for making proteins that keep muscle cells healthy and functional. Let's talk about what's actually going wrong at the cellular level. Your muscles are made up of millions of muscle fibers, and these fibers need to stay intact and functional for you to move around, breathe, pump blood through your heart, basically everything your muscles do. There are specific proteins in muscle cells that act like structural support, kind of like the framework of a building. One of the most important of these proteins is called dystrophin. Think of dystrophin as a shock absorber that protects muscle fibers from damage when they contract and relax. It connects the inside of the muscle fiber to the surrounding membrane, helping to stabilize everything during movement. In the most common and severe form of muscular dystrophy, called Duchenne muscular dystrophy, there's a genetic mutation that prevents the body from making dystrophin at all, or makes it produce a version that doesn't work properly. Without functional dystrophin, muscle fibers become fragile and easily damaged every time they contract. Over time, this repeated damage leads to muscle fibers breaking down faster than the body can repair them. The damaged muscle tissue gets replaced with fat and connective tissue, which obviously can't contract like muscle can, so you end up with progressive weakness. Different types of muscular dystrophy involve mutations in different genes that code for different proteins, but the end result is similar. Muscle fibers become unstable, get damaged, and eventually die off. Some forms affect mainly the muscles of the limbs, some affect the face and shoulders, others affect the muscles around the hips and thighs, and some affect multiple muscle groups, including the heart and respiratory muscles. Now, because muscular dystrophy is genetic, we need to talk about how it's inherited. Most forms of muscular dystrophy are inherited in one of three ways: X-linked recessive, autosomal dominant, or autosomal recessive. Understanding these inheritance patterns is crucial because it affects who gets the disease and how it's passed down through families. Duchenne and Becker muscular dystrophy, the two most common forms, are X-linked recessive. This means the mutated gene is located on the X chromosome. Males have one X and one Y chromosome, while females have two X chromosomes. If a male inherits an X chromosome with the dystrophin gene mutation, he'll develop the disease because he doesn't have another X chromosome with a normal copy of the gene to compensate. Females, on the other hand, usually need mutations on both X chromosomes to develop the full disease, which is extremely rare. However, females who carry one mutated copy can sometimes have mild symptoms and are called carriers. They can pass the mutated gene to their children. Their sons have a 50% chance of having the disease, and their daughters have a 50% chance of being carriers. Other types of muscular dystrophy follow autosomal dominant inheritance. This means you only need one mutated copy of the gene to develop the disease, and it can be inherited from either parent. Each child of an affected parent has a 50% chance of inheriting the mutation. Myotonic dystrophy and facioscapulohumeral muscular dystrophy often follow this pattern. Then there's autosomal recessive inheritance, where you need two mutated copies of the gene, one from each parent, to develop the disease. Both parents are usually carriers who don't have symptoms themselves but each carry one mutated copy. Each child has a 25% chance of inheriting both mutated copies and developing the disease, a 50% chance of being a carrier, and a 25% chance of inheriting two normal copies. Sometimes, muscular dystrophy can also occur from new spontaneous mutations, meaning there's no family history of the disease. The mutation just happens randomly during the formation of the egg or sperm, or very early in embryonic development. Let's move on to what muscular dystrophy actually looks like in terms of symptoms. Remember, there are many different types, and they can present very differently, but I'll give you a general overview and highlight some specific patterns. The hallmark symptom across all types is progressive muscle weakness. This usually starts in specific muscle groups depending on the type of muscular dystrophy and gradually spreads to other muscles. In Duchenne muscular dystrophy, which typically affects boys and shows up in early childhood, the weakness usually starts in the muscles closest to the trunk of the body, the hips, pelvis, thighs, and shoulders. Parents might notice that their child has trouble running, jumping, or climbing stairs. The child might walk on their toes or have a waddling gait. There's also this characteristic sign called Gower's sign, where the child has to use their hands and arms to walk up their own body to get from a sitting or lying position to standing, because their hip and thigh muscles are too weak to push them up normally. As Duchenne muscular dystrophy progresses, kids typically lose the ability to walk by their early teens. The weakness continues to spread to the arms and other muscles. One thing that can seem paradoxical is that the calf muscles often look enlarged, which you might think means they're getting stronger. But it's actually what we call pseudohypertrophy. The muscle tissue is being replaced by fat and connective tissue, making the calves look bigger even though they're actually weaker. Becker muscular dystrophy is similar to Duchenne but milder and progresses more slowly. It's also caused by mutations in the dystrophin gene, but the body can still produce some functional dystrophin, just not as much as normal or not fully functional. Symptoms usually appear later, often in the teens or 20s, and people with Becker can often walk into their 30s or beyond. Other types have different patterns. Facioscapulohumeral muscular dystrophy, as the name suggests, affects the muscles of the face, shoulder blades, and upper arms. People might have trouble raising their arms above their heads, and their face might have reduced expression, difficulty smiling, whistling, or closing their eyes completely. This type usually shows up in the teen years or early adulthood. Myotonic dystrophy is unique because it involves not just muscle weakness but also myotonia, a delayed relaxation of muscles after contraction. So someone might shake your hand and then have trouble letting go because their hand muscles stay contracted for a few extra seconds. This type also causes other problems beyond the muscles, like cataracts, heart rhythm abnormalities, hormonal issues, and cognitive difficulties. Limb-girdle muscular dystrophy affects the muscles around the shoulders and hips, and there are actually many subtypes with different genetic causes and slightly different presentations. Symptoms can begin in childhood or adulthood depending on the specific type. Beyond the muscle weakness itself, there are several complications that can develop. Many forms of muscular dystrophy affect the heart muscle, leading to cardiomyopathy, where the heart becomes weakened and enlarged, or arrhythmias, where the heart rhythm becomes irregular. This is actually one of the leading causes of death in people with muscular dystrophy. The breathing muscles, including the diaphragm, can also be affected, leading to respiratory insufficiency. People might have trouble breathing deeply, especially when lying down, and they become more prone to lung infections. Some people eventually need ventilatory support. Skeletal problems are common too. As muscles weaken, they can't support the skeleton properly, leading to scoliosis, a sideways curvature of the spine. Joints can develop contractures where they get stuck in bent positions because the muscles and tendons become tight and shortened. Mobility issues often lead to weight gain, which makes muscle weakness even more problematic. Depending on the type, there can be other effects too: difficulty swallowing, which increases choking risk and can lead to malnutrition, cognitive or learning disabilities in some types, and endocrine problems. So how do doctors actually diagnose muscular dystrophy? It usually starts with noticing the symptoms I just described. A child who's having trouble walking, falling frequently, or showing developmental delays in motor skills might prompt an evaluation. Family history is really important. If there are other family members with muscle problems or muscular dystrophy, that raises suspicion. The physical examination is crucial. Doctors look at muscle strength in different muscle groups, check reflexes, observe how the person walks and moves, and look for specific signs like pseudohypertrophy of the calves or Gower's sign. They'll assess range of motion in the joints and check for contractures. One of the first laboratory tests that often gets ordered is creatine kinase, or CK. This is an enzyme that's normally found inside muscle cells. When muscle fibers are damaged and breaking down, CK leaks out into the bloodstream, so blood levels become elevated. In Duchenne muscular dystrophy, CK levels can be 10 to 100 times higher than normal. Even before symptoms become obvious, an elevated CK isn't specific to muscular dystrophy. It can happen with any muscle damage, but it's a red flag that something's going on with the muscles. Electromyography, or EMG, is another test that can be helpful. This involves inserting small needles into muscles to measure their electrical activity. The pattern of electrical signals can help distinguish muscular dystrophy from nerve disorders or other muscle diseases. In muscular dystrophy, the EMG typically shows a myopathic pattern with small, short-duration motor unit potentials. Muscle biopsy used to be the gold standard for diagnosis. A small piece of muscle tissue is removed, usually from the thigh, and examined under a microscope. In muscular dystrophy, you see characteristic changes like variation in muscle fiber size, muscle fibers in different stages of degeneration and regeneration, increased connective tissue and fat replacing muscle, and often inflammatory cells. Special staining can detect the presence or absence of specific proteins like dystrophin. If dystrophin is absent or severely reduced, that confirms Duchenne or Becker muscular dystrophy. However, genetic testing has become increasingly important and is now often the preferred diagnostic method. A blood sample can be analyzed to look for mutations in the genes known to cause different types of muscular dystrophy. For Duchenne and Becker, they look for deletions, duplications, or point mutations in the dystrophin gene. For other types, they test the appropriate genes. Genetic testing can definitively identify the specific type of muscular dystrophy, which is important for prognosis and genetic counseling. It can also identify carriers and families. Sometimes, if genetic testing doesn't find a mutation but there's still strong clinical suspicion, or if doctors want to confirm the functional effect of a genetic variant, a muscle biopsy might still be performed. The two tests together give the most complete picture. Imaging studies like MRI of the muscles can show patterns of muscle involvement and help distinguish between different types of muscular dystrophy. Heart monitoring with electrocardiograms and echocardiograms is important to check for cardiac involvement. Pulmonary function tests assess breathing strength and lung capacity. Once a diagnosis is made, what can actually be done about it? I need to be straight with you here. There's currently no cure for muscular dystrophy. The genetic mutations that cause it are present in every cell of the body, and we don't yet have the technology to fix those mutations throughout the entire body, though gene therapy research is making progress, and I'll come back to that. However, there's a lot that can be done to manage symptoms, slow progression, prevent complications, and improve quality of life. Corticosteroids, particularly prednisone and deflazacort, are the main medications used for Duchenne muscular dystrophy. These are anti-inflammatory drugs that have been shown to slow muscle degeneration, preserve muscle strength for longer, and delay loss of walking ability by a few years. They probably work by reducing inflammation in the muscle and possibly by altering the immune response. The downside is that long-term steroid use has significant side effects including weight gain, bone weakening, growth suppression, mood changes, and increased infection risk, so the decision to use them involves weighing benefits and risks. Generally, they're started when the child is no longer gaining motor skills or when there's clear decline, usually around age 4 to 6. Physical therapy and occupational therapy are absolutely essential. Physical therapists work on stretching exercises to prevent or reduce contractures, strengthening exercises for muscles that aren't too weak, and techniques to maintain mobility and function as long as possible. They also help with assistive devices like braces, walkers, and eventually wheelchairs. The goal is to keep people as independent and mobile as possible. Occupational therapists help with activities of daily living, adapting the home environment, and maintaining arm and hand function. Orthopedic interventions can help too. Surgery can release contractures or stabilize the spine if scoliosis becomes severe. Braces can support weakened ankles or other joints. Adaptive equipment makes daily activities easier. Cardiac care is critical. Regular monitoring with EKGs and echocardiograms helps detect heart problems early. ACE inhibitors and beta blockers are often prescribed to protect the heart even before significant problems appear, as they've been shown to slow the progression of cardiomyopathy. If arrhythmias develop, antiarrhythmic medications or even pacemakers might be needed. Respiratory support becomes necessary as breathing muscles weaken. Non-invasive ventilation using a machine that delivers pressurized air through a mask can help at night when breathing is most challenging. This improves sleep quality, reduces morning headaches, and can prolong life. Eventually, some people need daytime ventilation support too. Techniques like cough assist devices help clear secretions from the lungs to prevent pneumonia. Vaccination against flu and pneumonia is really important to reduce infection risk. Nutritional support is another piece of the puzzle. A dietitian can help ensure adequate calorie and protein intake while avoiding excessive weight gain, which is a challenge especially with steroid use and reduced mobility. If swallowing becomes difficult, dietary modifications like thickened liquids or pured foods can help, and in severe cases, A feeding tube might be necessary to prevent aspiration and maintain nutrition. Now, let me talk about some of the newer, more exciting treatment developments. For Duchenne muscular dystrophy specifically, several drugs have been approved that target the underlying genetic defect, though they only work for specific mutations. Exon-skipping drugs like eteplirsen, golodirsen, vitolarsen, and casimersen are designed for people who have specific deletions in the dystrophin gene. These drugs work by causing the cellular machinery to skip over certain exons during the process of making the dystrophin protein, allowing the production of a shorter but partially functional version of the protein. Think of it like editing out a damaged paragraph from a book so the story still makes sense. These drugs don't work for everyone, only for people whose specific mutation is amenable to the particular exon that drug skips. But for those people, it can slow disease progression. The drugs are given by weekly intravenous infusions. Atalurin is another drug that works for a small subset of people with Duchenne, those who have what's called a nonsense mutation. This drug helps the cellular machinery read through the mutation and produce a full-length dystrophin protein. Gene therapy is probably the most exciting frontier. The basic idea is to deliver a functional copy of the dystrophin gene directly into muscle cells using a modified virus as a vehicle. This is incredibly challenging because the dystrophin gene is huge, too big to fit into the viral vectors we typically use for gene therapy. Scientists have developed a miniaturized version called microdystrophin that contains the most essential parts of the gene. Early clinical trials have shown that this approach can successfully deliver the gene to muscles and produce microdystrophin protein, with some patients showing stabilization or even improvement in muscle function. Several gene therapy products are now working through the clinical trial process, and one has recently been approved. This is genuinely revolutionary, though we're still learning about long-term effects and optimal dosing. There's also research into CRISPR gene editing, which could potentially fix the mutation right in the DNA, and approaches to boost the production of related proteins that can partially compensate for the lack of dystrophin. For other types of muscular dystrophy, treatment options are more limited and mostly supportive, but research is ongoing for type-specific therapies. Living with muscular dystrophy requires a comprehensive, multidisciplinary approach. Regular follow-up with a team that might include neurologists, cardiologists, pulmonologists, orthopedic surgeons, physical and occupational therapists, dietitians, and social workers is important. Psychological support for both patients and families is valuable, as dealing with a progressive, life-limiting condition is emotionally challenging. The prognosis varies dramatically depending on the type. Duchenne muscular dystrophy, unfortunately, has the most severe course. Without treatment, boys typically lose the ability to walk around age 10 and often don't survive beyond their late teens or early 20s, usually due to respiratory or cardiac complications. With modern comprehensive care including steroids, cardiac medications, and respiratory support, life expectancy has improved significantly, with many now surviving into their 30s or beyond. Becker muscular dystrophy has a much more variable course, with some people having near-normal lifespans. Other types like facioscapulohumeral and limb-girdle muscular dystrophy generally have slower progression, and many people have normal or near-normal life expectancy. Though with increasing disability over time, myotonic dystrophy's outlook depends on the severity and can range from minimal symptoms to significant disability. The key thing to understand about muscular dystrophy is that while the different types are caused by different genetic mutations affecting different proteins, they all result in progressive muscle weakness through similar mechanisms of muscle fiber damage and degeneration. The genetic nature means it's inherited in predictable patterns, and genetic testing has become crucial for diagnosis and family planning. While we can't yet cure these diseases, supportive care has improved dramatically, and emerging targeted therapies and gene therapy are starting to change the landscape, offering real hope for slowing or even halting disease progression. Prevention isn't really possible for muscular dystrophy in the traditional sense since it's genetic, but genetic counseling can help families understand their risks. Carrier testing can identify women who carry mutations for X-linked types, and prenatal testing or pre-implantation genetic diagnosis with IVF can allow families to make informed reproductive choices. So that's muscular dystrophy, a complex group of genetic muscle diseases that progressively weaken the body's muscles through various protein deficiencies, diagnosed through a combination of clinical assessment, blood tests, genetic testing, and sometimes muscle biopsy, and managed with a multidisciplinary approach including medications, physical therapy, cardiac and respiratory support, and increasingly, targeted genetic therapies. Research continues to push forward, giving hope for better treatments and eventually cures. Thanks for sticking with me through this deep dive. If you found this helpful, go ahead and hit that like button, subscribe if you haven't already, and let me know in the comments what topic you'd like me to cover next. I'll see you in the next one.